Please, Sister Muna, lighten the coming 1 hour and share with us some of your experience, hard work you are doing at Royal Hospital.
Thank you, Dr. Ahmed, for giving me this great opportunity to share our Royal Hospital experience about Pediatric Rapid Response Initiative. First of all, we are going to, within this 1 hour, inshallah, it will be even less. We are going just to start to know what is the reason for failure to rescue, and then we will go to know about what is the rapid response team, and then the scientific evidence supporting rapid response team. Also, we will share the experience of adult critical care. So at the beginning, as you know, all of you, children in the world often experience unrecognized deterioration that may progress to cardiac pulmonary arrest with poor prognosis. Between 0.7 to 3% of hospitalized children have cardiac pulmonary arrest, and as we know that all the outcome is poor. So only 15 to 36% of children surviving to discharge. Interestingly here, some of the people that are saying that the children that are arresting or fail to rescue suddenly, but many literature supporting that, a wide literature stressing it's not a sudden. The children shows signs and symptoms of deterioration for hours and estimated between 6 to 8 hours. So we could retrieve the child from the cardiac pulmonary arrest. Several studies mentioned that we could know about it, and abnormal vital signs can help us to identify the clinical deterioration in patients minute to hour before the serious adverse event. So just I want to share that there is some of the literature shows there is 3 fundamental causes led to the failure to rescue in the hospitals. If we can go with the first one, which is either there is a failure or poorly recognized early signs of deterioration in patients' hemodynamic condition. The second one, breakdown or ineffective communication between teams, either nurses, doctors, about the child clinical condition. The third one is the poorly managed, especially or ineffective management, especially if the child, if there is a different layers of treatment. This all can be a factor of delay in rescue of children in the general wards.
Nice. So now we know that poor recognition, communication, and poor management led to failure to rescue sick patients. But how we can prevent such failures?
Thank you, Dr. Ahmed, for the great question. Yes, actually, we could prevent the failure to rescue. Just before I start, I could just give you to share our experience regarding failure to rescue. In 2013, we had mortality cases that can be, and then the mortality cases, actually, it's also the team through child health, morbidity and mortality, when they did a root cause analysis, they found that the children can be rescued and retrieved as early as possible. So through their action plan, they could manage that. Why we shouldn't establish pediatric rapid response service, and as it will help to integrate all of the factors that I mentioned before, and it will help in causing failure to rescue. So it's Dr. Saad Ismaili, she was leading in 2013 the project. So if we'll go to know what is Pediatric Rapid Response Team, is a multidisciplinary group of staff within the hospital that can bring pediatric specific critical care expertise to the patient's bedside. As you know, sometimes there is no bed at an ICU to wait for the patient. So instead of waiting for a bed, the expertise from the critical care can go to the patient's bedside as a way to improve clinical outcome. And you can see in some of the literature, it's called Rapid Response Team or it can call critical access team or medical emergency team, or adult, they're using acronym which is critical care outreach team, CCOT. So why it is created? Actually, we created, as mentioned before, it will improve the recognition and the response of deterioration of the patient in general wards, as well as it will reduce the incident of cardiopulmonary arrest and the hospital mortality through the assessment of the patient's condition as early stage of the clinical deterioration. The team can also recommend as early intervention and transfer to the either high D level or ISO level if required.
Nice. So after knowing the advantages, Muna, of having rapid response team, can you tell us about the evidence behind such interventions? Is there any strong evidence supporting such projects to be implemented in our hospitals?
Yes, there is a wide literature regarding the rapid response, and it's through implemented through 20 years actually. But because of the time limit, I will highlight two. There is like one of the literature is mentioning they did a review for some of the literature regarding the implementation of and the benefit of the rapid response team in pediatric. So if we'll go with the Shark et al. In 2007, when they the first literature that they studied the rapid response implementation, and they found it's a great opportunity that the main mortality, it was reduced by 18%, as well as the code reduced to 71%. And even the other literature also, it's supporting that it will, through the rapid response team implementation, it will decrease the rate of mortality as well as the code. If we will go to the one of the study, they studied I mentioned it's a systematic review and meta-analysis. They studied both the effect of the rapid response in both adult and pediatric. Here is the interesting point. In the meta-analysis concluded that in adult implementation, rapid response team was associated with the statistical reduction of non-ICU patients with a cardiopulmonary arrest reduction of 33.8%. Whereas in children, the cardiopulmonary arrest, it is more than adult, which is 37.7. The interesting point here, in adult, rapid response didn't show, it didn't lower the mortality. However, in pediatric, the mortality level, it's reduced to 21.4%. So I will share also one more. There are so many studies that it's not only the activation of the rapid response by the staff or the vital team in the hospital. They went beyond than that. Now the family, they could activate the rapid response by themselves. Most of the hospital and the wards, they are teaching the family that they can activate if they are worried about their child condition, or they will teach them if there is some of the signs that they could see different in their children. So they will teach them the number that they can call the rapid response. And many studies mentioned that the perception, it was highly satisfaction from the staff, patient, as well as the staff. And also it's good, the effect also, it was a great on the children as well as in preventing cardiopulmonary arrest. So here also I would like to mention regarding the experience of Royal Hospital. This is one of the evidences that in adult. So they actually in 2010, they did the pre-implementation of the CCOT, which is same like rapid response team. It was in 2010, it was 100 arrests. When in 2011, they implemented CCOT, and you could see here, it's a rapid reduction in the cardiopulmonary arrest. See, in up to 2017, the arrest went to 20 from the 100 cases. And also here you can see they started first with medical, and then in 2015 they also integrated the surgical wards. So this is the point that some of the evidences, but because of short time, I couldn't go further. So how we could implement rapid response in pediatric settings. So we could go with the 3 stages. We did planning stage through the more, as we said, because it started from the mortality and morbidity committee and child health. And then after planning, we did a piloting in one of the ward. And then we did implementation by training and all. I will mention it later. So before than that, let me first to tell you what is actually how it went through 3 components. So during planning stage, we thought we need a criteria and a system for notifying and activating the response team. And we got the criteria with Australian team who contacted them in 2014. And we adopted the Australian criteria of the pediatric early warning score. And then we identify our response team. And also we had a criteria for the response team, who is the response team, and how we can teach them. The third one also, we also studied how we could do the quality improvement and to train the staff and to analyze the data and to provide the feedback for the continuous improvement. So then the response team, it will be a ward registrar. Actually, it shouldn't, because we want to retrieve the patient as early as possible. So to prevent the layer of recognition, delay in recognition. So the most senior, it is the ward registrar and the ward. He will be within the response team, and then a trained nurse in pediatric ICU with a valid PALS certificate. And the nurse in PICU, she should be not junior. I mean, it should be more than 4 years experience in pediatric ICU. The third important person in the rapid response team, which is the primary bedside nurse. And the one of the, just I didn't write it here, which is also we are considering them a rapid response team, which is the respiratory therapist, where they are included as well if the patients are needed in IV cases. So we did here our criteria here, because we have in Royal Hospital 3 wards, which is pediatric 1, 3, and 4. And in the future, because we want to cover pediatric surgery as well as the pediatric oncology. The team will not cover HIDE or ER because it's considered they are critical care. So our journey, we started the pediatric rapid response in 2014. We started, as I mentioned, training for the PRRT trainer by Australian team. And after that, they gave us a certificate of train the trainer. And then we trained 50% of the bedside nurses in pediatric 3 and pediatric 4 in November 2014. And we included permanent doctors as well. Services started in pediatric 3 as a pilot in April 2015, and in pediatric 4 in July 2015. After studying the effect in pediatric 3, it was really a great success, as then we could go further to pediatric 4. Service starting in pediatric 1 in 2017 after training 50% of the staff. So if you could see here, we didn't go direct for the service, but we need to train the nurses to understand who is the rapid response, as well as we didn't only train nurses, we trained all the permanent doctors who are in pediatric ward, because it will help facilitate the communication as well as the early recognition. So we actually, the rapid response team, depending on a tool, this tool is called Pediatric Early Warning Score. This tool, it is provide a highly reliable and valid clinical scoring data. It will score all vital signs parameters, is added to give a total views. The total views guide to correct level of escalation. As I mentioned before that, interestingly, that the vital signs, it can help in preventing deterioration, especially clinical deterioration, and the vital signs also we could retrieve it through the pediatric early warning score. So here's the chart. Actually, a little bit we face difficulty in pediatric, unlike adult. Adult, they don't have is age, according to the age level of children, but we have here a special age of children. You can see, for example, here in respiratory rate, we have the less than 3 months, from 3 to 12 months, from 1 to 4 years, and then from 5 to 11 years. The last is from 12 to 17 years, but we in pediatric, we need to see up to 13 years. So you can see here there's a traffic light. You can see there is green, yellow, orange, and red. So if it is zero, that means it is normal. If it is 1, that means the total abuse is 1. And then if it is 2 or 3 and 4. And then here is the respiratory rate. This is the heart rate. And also you could see it is similarly, it is a traffic light. And this is a systolic blood pressure. Also it is, and then oxygen saturation. Here also oxygen delivery and respiratory rate effort. So after gathering all the total score system, this is the criteria for how to escalate and what we need to do. So it will guide the nurses as well as the team what to do. So if the abuse is 1 to 3, it's considered to, like, it will help the nurse that what to do. For example, to perform perform 1 to 2 hourly vital signs. It will to calculate the abuse. She should inform the IC, and then from 4 to 5 if abuse. So if abuse more than 5 or equal to 5, to call for the rapid response team and monitor the intake and output. Of course, she needs to take her IC. If abuse 6 to 7, so to call rapid response immediately, and then to keep the patient under monitoring half an hourly. If patient remain abused more than 6 for 60 minutes, then to request HIDE. If abuse more than 6 or 8 or equal to 8, so to call rapid response team, inform the consultant, and then observation half an hourly, frequent if indicated, recommend transfer to the HIDE. If abuse more than 6 after 2 hours, consider BICU consultation. So here, actually, we train the staff to do it, to calculate it by themselves. But we are proud to say that Oman was the first country to put the vital abuse electronically. So so the rapid response goes electronic, which is we kept the abuse through Al Shifa system. It will calculate the scoring. If you could see, all the vital signs data entered in the Shifa system. So it will help to proactive identification and deteriorating children. You can see here that it will give the traffic light, and it will help you to see what is the color of the vitals. I mean, when you will do the vital signs, it will help you what is the abuse score. If you'll click here, the abuse score action to be taken, and then it will guide you what you need to do. For example, if you need to call the rapid response. So this is just for you to, this is the called value stream mapping. We kept it a little bit pictures, so you could see the sequence. So if this actually the staff and pediatric rapid response team, she is taking care of a patient in ICU. Still, she is not free for rapid response. So they will when the staff, she will do the vital signs, and then through the system, and then the Shifa system will see that the abuse is 5. Then she will call her. She will use the Spark communication tool. So it will help in good communication. And then the staff, she will go to see the patient. She will call the doctor same time, as well as she will go with the bedside nurse. And then in case she will need the respiratory therapist, and then she will call her as well. And then she needs to write everything in the system. If the patient needed either to be continued monitoring with the rapid response, or should be discharged with the rapid response. So it's a circle, actually. So as we mentioned, the vital signs should be performed and then interpreted by the nurse through views, and then she will communicate through SBAR. So it will help in communication level, and then the team will go to timely. They shouldn't delay, so it should be not more than 15 minutes. It should go before 15 minutes, and review the child by the team together, and then the vital signs interpreted again by the team, as well as later timely and appropriate management, either the child, he will go to the ID or ICU, or he remained under management of the rapid response till the patient, he will be stabilized, and then they will be reassessing the child for re-escalation if required, and then it will go sequence. So here is the when the Australian team, they came for the education and training. We trained the trainer. So, and then we trained the permanent doctors, the trainers, the nurses, as well as the focal points in pediatric ward. So this is our result now. In our result, the arrest rate in the ward, if you could see here, actually, it's in 2013, we did our survey. It was 2%. In 2015, it was sharp reduction to 0 arrests. But little bit in 2016, 17, and 18, little bit went high, but we stabilized like steadily in points up to 0.7, but in 2019 and 2020, we remained with 0 arrest rate in the ward. What about mortality rate here? Actually, in mortality rate, as we mentioned, before starting rapid response team, the mortality was 34%. If you could see here, the unplanned admission was 56 patients in between June 2012 to November 2013. And then the arrest in the ward, the deaths in the ward, it was 13. The deaths in PICU with the patient who came with unplanned, it was 6. So the total death, it was 34. After implementation rapid response in 2017 and 2018, it was reduced to 13%. However, it wasn't the unplanned admission was reduced, but not that significant because we are retrieving them as early as possible. And in 2019 and November to 2020, the mortality rate reduced further to 9.5%, as well as it was a good reduction in the unplanned admission. So now what we did here, we reviewed our policy through the rapid response team again. And then we did the responsibility and the use of the abuse score. And then you can find it in our Royal Hospital. It will help you to standardize it in the other units, in the other hospitals. So we are happy to share with you. So also in that also we kept the responsibility for the rapid response, what you should do. And then, for example, here, the follow-up of the patient who are transferred directly from the PICU to the ward, general ward, for 24 hours should be seen by rapid response. As well as here, also the ward registrar responsibility as well. Also, it is mentioned in our policy, and it's mentioned here, the management of the sick patient shouldn't be more than, they shouldn't be delayed than 15 to 30 minutes. So here we have actually a great challenge in the unplanned admission and some of the deterioration children and most of the patients with sepsis. So what we did here, we integrated, we have a sepsis team, which is not same like rapid response team. However, we introduced the abuse score in the recognition bundle. So if you could see here also, we do it as a traffic line, traffic with the red and yellow. And we mentioned here, it's depend on the abuse score, if it is between 3 to 4 or it is more than 5. What we need to do and how we could manage and retrieve the patient from the sepsis.
Good. Excellent, Ms. Muna. So now it seems we know that rapid response team has a very excellent effect on promoting the outcome of our critically sick patients, for those who are at high risk to be critical and at high risk of deterioration. But it seems that we are missing the effect of such projects on the medical team. I mean, mainly the nurses in regard of their satisfaction and their level of confidence. Means they will be calling a team to assess critically sick patients. So please, can you share with us if you have any work in regard of exploring these few issues in regard of nursing satisfaction and they are confident with dealing with critically sick patients?
Yeah, thank you, Dr. Ahmed. Actually, yes. After retrieving the information, the effectiveness of the primary outcome of the effect of rapid response, we thought let us to study the perception of the bedside nurses. Is it effective from their perception or no? So we did a semi-structured questionnaire, which and some of them open-ended. For the 50 nurses, we found that the effectiveness, 50% they said early, it will help in early recognition and management. 20% they said it's the communication improved, especially among the team. And 30% they said it's improved the collaboration and learning because they are learning between each other. So it was a great opportunity that it was also motivated the rapid response team to continue. As well as also we actually studied their satisfaction rate. You could see here most of the staff, sorry, highly satisfied, 18% highly satisfied, 30% satisfied, and then 12%, 12 they say fairly satisfied, which is it will help us in that. Other achievement, most of the staff they were satisfied. It's improved teamwork among critical care and the ward, as well as it's reduced the staff load because from the calling for the layers of the doctors and then follow up many times, the rapid response it will help them immediately so to come and manage the child as early as possible and then to facilitate for the bed in case there is no bed in Heidi, to facilitate the beds and to till the patient is safely transferred either to the Heidi or ICU, as well as also it's improved their confidence, especially when they are communicating, because we did a criteria for the communication. If they are not happy, they can call directly the consultant or directly to the ICU team. So this helped us in really give the nurses, giving them a power to communicate as well as to communicate with the doctors, to communicate with the rapid response, to communicate with even the consultant at home. And this rise the quality of care as well as the performance improvement.
Good, excellent. So, Mona, you know that with each new project or new initiatives, there should be an obstacles. So, please, can you share with us again what obstacles or challenges you have faced during your journey of this excellent work?
Yeah, actually, yeah, as we mentioned that because the nurses they were not only allocated for rapid response, they are taking care of a patient. So sometimes there is a delay in going to the patient immediately. So the staff allocated with patient in ICU, so there is a delay, as well as rapid response call sometimes during shift changes, and the nurse she will also delay to go to see the patient immediately. There is also because the rapid response is depending on the BUSE score. So the BUSE, if the vital signs is not complete or no compliance with SPAR communication or missing an accurate vital signs, also the service would be affected. The fourth one is lack of training because we have many nurses that now they are resigning and some of them are retiring. So we are getting new nurses. So we need to do continuous training and that's plus also the rapid response should be trained. Here also in June 2021, unfortunately, we because of COVID situation and pediatric ICU expansion, rapid response service was held. So what we did here, we retrieved the data. We want to study after that what happened. So number of unplanned admission within 7 months gone to 22, and we have 2 deaths. This is the challenges that we need actually to again to establish rapid response team. But we thought now our next is to do an extensive training for the rapid response staff by high fidelity simulation and introduce competencies. So it will help the rapid response to be more competent. As well as we need to introduce in the safety huddle all the patient who is abusing through, so it will help to the improved communication as well as the bedside training. We should also do it frequent for the ward staff. In summary, rapid response team have been introduced at hospital in many countries. It will set up an expert team to the bedside of the patient exhibiting signs of deterioration. It will facilitate the identification of the patient at risk and consider early intervention. It will encourage calling for help on time, being support for bedside nurses, as well as it will improve communication and teamwork among nurses. So remember, failure to rescue event by intervening early. So thank you. This is my references. And if you need anything, we are glad here in Royal Hospital, we can support you.